Martin.
Yeah, and welcome to the panel, Deputy. Constable Shenton. Okay, so we have an hour and a half for this hearing. As always, it's a lot of questions to get through. We may have to follow up in writing at points, and we have added an additional section, which I believe that's been run by you, Minister, and you're happy with that? Okay, fantastic. If you could first of all introduce yourself and the officers that you have sat at the table with you.
Okay, Tom Binet, Health Minister. We start from the other side.
Andy Weir, Director of Mental Health, Social Care and Community Services. Simon West, Medical Director for Health and Care Jersey.
Ruth Johnson, Director of Health Policy.
Peter Bradley, Medical Officer of Health, Director of Public Health.
Welcome everybody, and thank you for making time to come to the hearing today. There are some other officers that I believe you'll be swapping in and out, and your Assistant Minister, of course. Welcome. If you are swapping in, if you could introduce yourself when you begin answering the question, that would be great. Thank you. We're going to start with some follow-up questions around the changes around elective procedures, and of course there were some questions in the States Assembly recently, and also that we wrote a letter to you, which thank you for your response and the details contained within that. And you stated that there will be an increase in funding, review of treatments, and some requirement to reduce certain services. So my first question on this, Minister, is what specific Jersey-based factors will be used to assess the cost effectiveness in the new TIP policy, which is treatments and interventions prioritisation?
Right, I'm not able to answer that question directly, so I'm going to ask Peter. Peter, are you able to?
Yes, sure.
Yeah, thank you.
So the TIP policy is meant to achieve some consistency around existing committees. So there are a number of committees already that develop clinical policies across the health area. So the sorts of things that people would look at are obviously the health needs. So from the data, we would know how many people were coming forward for a particular treatment. They'd look at the research evidence about how effective that treatment would be, what the expected outcomes, and also look at the cost effectiveness, which isn't just purely looking at money. It's about what we can see as an investment for future health. And as I say, the real intention is to look at that and then to add to that a number of ethical criteria. So we need to look at things like inequity and other issues of that type to ensure that we have appropriate access to everybody on the island. But the real purpose is to achieve consistency.
Okay, thank you. You mentioned committees. Which are the committees? If it's not too long to...
Yes, I'm not sure I can give a complete list. I don't know whether we may need to come back to you. There's a number of existing committees at the moment.
Okay, that would be good if we could have that information. Thank you. And this is an NHS kind of policy that we're Jerseyfying. Is that correct to say?
As I understand it, similar.
Yes, so there will be NHS policies. So, for example, if we look at some of the NICE guidance, which would be familiar to some people, they look at a particular topic and then they make some recommendations, and they're particularly interested in new therapies. But there are factors that are important to Jersey that mean that we can't always implement those policies in exactly the same way. So, for example, there may not be a particular specialist on the island, and it's really important that they're adapted so that we do the very best for people on the island. So that would certainly be one element of this work. Some of it would be about policies that are already in place in Jersey, and it's just a question, as I say, of achieving more consistency.
Thank you, that's helpful. So you mentioned on-island specialists, and obviously there would be a difference there. And you also mentioned inequity around health, which I know there have been some reports from Public Health, which the panel have read with interest. What Jersey factors around inequity or inequality do you think need to be taken into account?
So I think they're very specific to the clinical area that we're looking at, but Jersey experiences the same types of inequity that you might experience in other places. So it's well known that, for example, people who have mental health conditions often have difficulty accessing. We've recently done the JSNA on women's health. There are many reasons, and it is quite particular to a particular clinical area. I just think it's one of those things that we need to look at every time we develop a new policy or a new clinical treatment.
Okay. And I want to just gently challenge back at the Minister there. I understand the advice from your officer there that the inequities will be largely comparable. But Minister, have you consulted with any stakeholders on Ireland to try to establish where there might be some differences, perhaps in the Jersey population, that we might need to take account of?
No, I haven't.
Is that something that you could do? I'm aware that there are groups that make recommendations to ministers around disabilities. I can't remember the names of the groups. Could you just seek to hear from those groups when you're forming this policy?
Something I'm sure, Peter, that we could take into account.
Yes.
Yeah.
Thank you.
That's fine.
Thank you. Okay, and that actually leads me on to my next question. What public consultation or stakeholder engagement are you planning?
Is there going to be consultation at the end of this, or is this an internal?
So, Bruce, can you remember the details? There's been quite a lot of stakeholder consultation already about this, and largely this is about, at the moment, it is about ensuring that there is more consistency of the existing policies. I think that we would think about public consultation if there was an area of interest, because I think it's hard to have that kind of engagement about something that's a bit more theoretical. But I think that if there were an area of particular interest, that would be the point. So we would certainly do that in any other area of interest, such as we've shown in the JSNA, but I think it would be better run as a topic-specific consultation.
So I think that's correct. In the development of the TIC policy, the way in which to see the TIC policy is that it is not a policy per se. It is a framework in which decisions are made. And in the development of that framework in which decisions are made, obviously clinicians and internal stakeholders have been consulted, and that includes those who are engaged in the existing committees that make decisions, which Peter mentioned earlier. So, for example, there is a committee that looks at high-cost drugs, but just looks at high-cost drugs, doesn't also look at high-cost surgeries or so on and so forth. So all the clinicians who are currently involved in those existing committees have been engaged and consulted in the process to develop TIP, which is this new decision-making framework. Where TIP is making or considering the making of decisions, which would need to be ratified by the Minister on the advice of the Advisory Board, where that's creating significant change or potential change, we will, on a case-by-case basis, look at what the best form of either general public stakeholder consultation is, or very specific stakeholder consultation, depending on the groups affected.
Okay.
In answer to the question, that has yet to be determined.
Yes,
That will
yes.
come at the end of the process.
Yeah.
So there's no, when you ask the question, is there anything specifically prearranged? And the answer to that would be no.
Okay.
Minister, in the Assembly on the 8th of September, you said you were asked about publishing terms of reference for it, and you said you would, for the review of elective surgery, and you said that you would publish any information that you could relating to this review. Do you have any information to publish, and if so, when will it be
I
published?
believe there is some, but I don't think it's a formal terms of reference. If you could
So
correct me on that.
that's correct. There weren't formal terms of reference for this review, but what we did do is we have written out and described the process that was stepped through in the development of this policy, how we went about it, who was consulted. I wasn't aware that hadn't been submitted to yourself and the Assembly as of yet. We will chase that up. We have the information.
And when would you expect this process of reviewing elective procedures to be finished?
Oh,
So I'm not doing it, so
I can't answer
I would
that.
need to
I'm
be guided
afraid.
by you. Because,
The as I understand it, and I think Peter will have more information, it will be an ongoing process. So they will be first of all looking at okay. So there are. This is where it gets quite complicated. There are two pieces of work happening. There is the creation of TIP, which is this new framework for making decisions. And underneath TIP, there are a number of sub-policies that exist. The sub-policy that exists, which is the one that you yourself asked the state's question about, is about procedures rather than, for example, medicines and other treatments and interventions. That policy, which has got various different names, but essentially is focused on surgical procedures of low clinical value, that work has already started. That is primarily and predominantly a desk-based piece of research at this moment, looking at the evidence of the clinical value of procedures in other jurisdictions. That will then move into the TIP framework to be considered as a wider group by the wider group for determination. I don't know what the end date for that work will be.
I mean, this review was announced in the media in August, this review of elective procedures in particular, in the context of health funding and the fact that the Minister was asking for extra money for health, and he had to justify that. To justify that, he had to show that he was applying value for money in the other parts of the health expenditure. So at some point, there will be an expectation that this is going to save money, or not. Is that not the case?
Yeah, I don't think it relates too directly. We're not asking for more money specifically for this because this is a piece of work that I think would probably have been needed with all of that extra money. I think the extra funding issue is a far broader issue than
But when you announced this, made the public statement, you said, we're asking for more money, therefore I have to justify to the public that we are spending all the money that we are spending.
That's absolutely
accurately.
correct, but it's a broad statement within which this particular element sits as a part of that process. And as I say, in the scheme of things, probably a relatively minor part of the process because it's work that needs to be done anyway. Because the statement about needing to justify extra money, I thought was an opportune moment when you're asking for extra money to assure people that as a team, we're looking to do all we can to save money wherever we can. The last thing we want to do is ask for money if we're not comfortable that we're making every effort to save the money, to spend the money that we're having wisely. I think that was a general statement that tried to contextualise the announcement.
I think the hair it sets running is that some treatments that were free are no longer going to be free.
Oh.
And that might be a two-tier health service in the making, where if you can afford a service to pay for something, you get it.
Well,
Do you acknowledge that?
I do. I think
fear
we're
exists?
strolling into the area of health funding, and I'm very happy to discuss that at length if you want. The point that looking at this in the overall, I've tried to change, since I've been in office, I've tried to change the narrative from this consistent claim of overspend to say to people, actually, we're not providing the right level of funding to health to get the job done properly in the first place. So that's the background that I come from here, to changing the narrative, to say to people, if you're going to keep living longer and you're going to want more and more treatments and you're going to want all the up-to-date drugs, all the up-to-date procedures, then you have to realise that either you're going to have to pay more for it, and in overall terms, in some form of overall taxation.
I understand that, Minister, but I was asking about elective procedures which you were reviewing in order to see whether they were all justified. And the question is, if some of them are judged to be not justified, that means they will only be available if you're prepared to pay for them.
In fairness, you did use the term, well, we're moving to a two-tier health service. And I once again, I tried to put some meat on the bone to give further evidence to the direction of travel. You can understand where I'm coming from, I hope.
How much money do you think will be saved after this review?
Oh, I personally have no idea. As I say, you'd have to look at somebody who's
Do you have a
more
ballpark?
professionally involved than I am.
So I think the answer to
Can
that
I just-
question is that we can't give you an answer to that question. In terms of, to answer your question, there was a policy that was in existence before TIP, which was clinical prioritisation policy with respect to individual treatments, which I think we've shared before in relation to some parishioners. This is evidence-based allocation of public funding to ensure the best delivery of care, which is recognised within surgical pathways for the benefit of all patients. So if you're if you're going to be put on a waiting list for a procedure, you should really only be put onto a waiting list for a procedure which is clinically validated and shows value for money. There's plenty of work. It does come from the UK. It's been around for about 20 years, so it's had a long track record of working, that shows that this is prioritising the allocation of funding to procedures which deliver the greatest benefit to patients. If we're going to allocate funding to patients for procedures which don't allocate or deliver any significant benefit, that's a waste of public funding. So we have a policy already in existence. To answer your question, that policy was here when I arrived 2 years ago. It's been in the process of updating to make sure that it aligns with the most recent data in terms of validated pathways, what delivers the best value for money, what is a good procedure, what isn't a good procedure. And it is now back out with the clinical body for consultation. In terms of how long that would take, I would expect it to take at least another 2 months so that we start the new financial year with the pathway embedded.
Okay, thank you. So Minister, just to reflect on what your officer has said, the policy intention behind this review, is it to improve patient outcomes rather than to make savings?
The intention is essentially to improve patient outcomes.
Yeah.
If
So
it
it-
does or
maybe the
doesn't,
unintended consequence.
yes, as I
Yeah.
say, the focus is on the patient.
Okay, so it's possible that the same amount of money would be spent, but the outcome would be improved health
As I say,
patients.
I can't predict the outcome. It's work in progress, but that could be one of the possible outcomes. I think it's safe to say.
Okay, so the driving force isn't saving money.
No, but by the same token, we do have to justify that the saving that we have to prove that we're efficient. If that makes sense.
I think my only comeback on that would be that there are disputes around what is considered a cost-effective treatment, and we indeed have had correspondence from people who've claimed that they are not being able to access treatment which they regard as vital for their health. So what transparency will there be around that decision making?
So within the policy, there are, if you like, get out of jail free cards in terms of where a procedure may be either unfunded or provided with limited funding. There are set criteria by which people can act with the health service to say, well, I know it's not funded, but in my case, I think it should be funded because, and that is the reason why we have those committees, which have been alluded to hear those cases individually. So if somebody, for example, wants varicose vein surgery, which is fairly rare these days in terms of the United Kingdom, but more so here, then you would be able to go to lodge an appeal that come to one of those committees where an individual case would be heard, and that might result in an individual patient funding request and that person being able to access that surgery.
Thank you. If you could send us that list of the committees and also information on how that's communicated to patients so that they know that there is a route to appeal or to advocate in that way. Thank you. And we're going to move on now to a section on women's health, which has a few areas underneath it, and Deputy Stevenson is going to open with some questions about IVF. So yes, if you need to move anybody around, please do so. And if the people who just sat at the table could introduce themselves.
Yes, so my name's Andy Howell. I'm Assistant Minister for Health and Social Services.
Thank you, welcome.
And I'm Ros Bullenbell, Director of Midwifery and Nursing for Women and Children.
Hello.
Thank you. As the Chair said, we're going to start with some questions on IVF. I think you're well used to some questions on IVF at the moment. Among us, we've asked a few very recently, particularly in light of the figures that showed there was some budget, as it were, left, only 10% I think of the budget spent to a certain point in the year. We've had some answers around the potential for extending the eligibility criteria, and I think you said you were going to review it at some point. Can you provide an update to us, please?
So thank you for asking the question. I do recognise that we are underspent on budget, and for that reason, I'd like to announce today that we are going to be making changes from October the 1st to some of the criteria, so that, because we really want, I recognise that it's really hard for couples who long to have a child, and the challenges that they face when it's not straightforward. And when the first round of changes to IVF funding were announced last year, I committed to keeping these under review in the hope that we would be able to extend the offer and support more couples with IVF funding, with a caveat. So I'm delighted that we're now in that position. So we're going to make 3 changes. The first is access for couples with children from previous relationships. The current policy says that if you're not eligible for funded IVF, you're not eligible if either of you or your partner already have children, whether from your current relationship or a previous relationship. And this includes adopted children and biological children. The amended policy will say you are eligible for funded IVF if you or your partner already have children from a previous relationship. So this, I hope, will allow couples where one of the partners does not currently have a child to access funded IVF and potentially have a child together.
So one of them's got to not have a child,
Yes.
to qualify for the new criteria.
Correct.
Okay.
The second is we're going to remove the requirement to be resident in Jersey for 1 year for certain people. The current policy says that you and your partner must be ordinary resident in Jersey for at least 12 months immediately before treatment. The amended policy will say you and your partner must be eligible for HCJ-funded healthcare in accordance with HCJ policies. And this allows long-term Jersey residents who have left Jersey for a few years to return home and to access funded IVF in the same way they can access other HCJ-funded services. So they don't have to wait for a year when they've come back. And the third one is something that perhaps Deputy Dublé might like. The current bits are removing infertility requirement for same-sex female couples. The current policy says you must be infertile as a couple to access funded IVF. For same-sex female couples, this means you are required to have used artificial insemination and have not become pregnant after 12 cycles, 6 of which used intrauterine insemination. The amended policy will remove the infertility requirement for same-sex female couples, i.e. they will not need to undertake artificial insemination to prove infertility. Please note, this does not include the funding of donor sperm or eggs. As per current policy, we will not refund the costs and sourcing of donor eggs or sperm if required.
Understood. Thank you. Thank you very much
So
for that.
I'm really pleased that we're bringing this forward early, because I really felt that we've got the funding and we should be using it for as many people as who we can help as possible.
Do you have any estimates about the number of couples that who may now qualify, or what the uptake may be?
It's very, very hard. It's like putting a finger up in the wind. So it's really hard to predict demand, and that's the trouble with all of this, because we're sort of flying blind, but we're hoping we're going to help more couples.
So what we have tried to do, and as the Deputy says, it's very, very difficult because we don't really have data in this area. We are trying to make estimates based on various and different data sources. But if we look at the number of public patients that we have for IVF in Jersey, if we look at the number of private patients that we have in Jersey who we know about because they are sourcing IVF through the assisted reproduction unit, as opposed to sole private patients that aren't coming near the assisted reproduction unit. We estimate that within a full 12 months of the new criteria operating, so that's not the first 12 months, i.e. this year, but 12 months from October to October next year. We had as you know, we had an available budget of 620,000. We think that this is going to cost around 614,000. And part of the reasons why you get that increase in costs is the more people that we have coming through, the more staffing we need. So to date, because numbers have been quite low, staffing has been within the existing contingent. As we get more patients coming through, the staffing within the unit is going to increase. And the other thing it might be helpful to understand, because there is a time lag in the financial data that we provide, when a question about IVF funding was recently answered in the States Assembly, we said that I think it was 64,000, about 10% of the budget had been spent. That information was correct at the time based on the data that we have at the time. But what we have done is we have gone back to our financial data and we have looked not just at the spend that's gone out of our budget, but the committed spend through the people that we know are coming through, because their IVF has already been agreed, it is simply waiting to happen. And so from January this year to August this year, so before we implement these new changes, it's not 64,000, it's actually 211,000. Sure. So that 64,000 figure, I think has kind of created some concern about it being very low. It is actually the spend is higher,
but still on the same number of people, or is it more people?
Oh, it's more people. So combination of some more people, but also the actual invoicing and costs associated with committed people coming through the system.
Sure.
Does that make sense?
Would it be possible to ask to have those more rounded figures?
We can certainly provide those more rounded figures to you.
Thank you.
So based on the fact that current spend is higher than we previously indicated it was, we've actually spent about a third of the budget, not 10% of the budget, and based on these changes, we are expecting around 614,000 of the 620 will be spent. But as the Assistant Minister has indicated, we will continue to keep that under review, because our predictions may be incorrect, they may be higher or they may be lower, and we need to address those as we go along.
Thank you. I've got two questions, and just to echo Deputy Stevenson's thoughts on that. Thank you, and I'm delighted for not just for the LGBTQ community, but for families across the board who need to access this. But a question about the same-sex couples access. Do you know how much of a saving that will be, not having to self-fund those kind of 12 cycles, just roughly? And if you don't, it can follow in writing, that's fine. And also communication on this. So in terms of the same-sex parental rights, I think large portions of the community have been left very confused because they haven't recently been very well communicated with. Now, this is a really big change and will be a really big moment for that community. How are you planning to get the message out there?
I will go to the press, and I'm sure that I will work with our policy officers and others in public health to get the message across.
So this afternoon, after the Assistant Minister's told the panel this, we're going to put out an initial press announcement explaining that to people. We're going to update the Government of Jersey website, will be updated from 2:00 today, saying that these changes come into force from the 1st of October. We've moved at pace to do this. We recognise that we now need to do some proactive communications around it.
Yeah, okay. And if we were to make some suggestions, is that something you'd be open to?
Yes,
Okay,
I'm very happy to listen to suggestions.
Great, thank you. And the other question, you mentioned the criteria may be further reviewed. And one of the criteria that I'd like to ask you about is for single parents. For people who obviously couldn't prove infertility if they are single, how would could they be covered with this as well?
Well, at the moment, we're just looking after couples, because I think that's Deputy Stevenson in her proposition was very clear that it was for couples. And that is what we're dealing with at the moment. And we just have to see how this moves forward.
Have you done
any?
It's
also unfair on gay men as well, isn't it?
Have you done any financial modelling? Say, if you were to extend it to single parents, in the first instance, what that might cost?
So we have tried, but as I say, our data sets are very sparse and they've got big holes in them. So when we initially started the work over a year ago, we looked at different options, and it is quite clear from the fact that we've spent 200,000 out of a 600,000 budget that our initial forecasting was not as accurate as it could have been, which therefore casts a light on the rest of our forecasting, which we always recognise might be incorrect because of the gaps in our data. But I think that if within the next 12 months we do spend £614,000, clearly there would not be sufficient budget within that 260 to open the doors for single women as well.
And can I ask the Assistant Minister then? So if the money isn't spent, what would be your next criteria? Would it be single parents, or would it be, I think maybe Deputy Stevenson might have supplementary to that in terms of other criteria?
I would need to come back to Tiny Seeds and Deputy Stevenson and work with the panel, with them to see which area, if we are underspent, we should look at next.
I would just, I think a practical question, because there will be people out there today who will take this as real good news and they'll be ringing up ARU tomorrow kind of thing. If they've self-funded in the past 6, 7, 8 months, there is a potential that counts them out of this funding if they now come into it. Where does that fit? Have you considered that at all?
Something in my heart, I really would like to support them, but I think it's really hard whether we.
So the current criteria for access say that it's up to 3 rounds of IVF, and any previous self-funded rounds count towards those 3. We within the modelling we've done, we are assuming that criteria is maintained, i.e. if you have self-funded, that counts towards your 3. I do recognise, however, that when we first introduced this policy, we created an airspace for people who had just funded IVF, and that is something that we will think about, and we will have done that before the 1st of October.
Minister, do you have some discretion in that area as well?
I'd like to think I have.
Okay. I think, did you?
Oh, yes, thank you. As I'm new to this panel, but also as somebody who's campaigned for infertility treatment for over 30 years, I'm thrilled with this announcement this afternoon. And I know that the budget will be severely impacted by this announcement, but I still would like to ask, because we've been asked, since treatment occurs off island, will the department consider funding travel or accommodation assistance, given that this remains a significant barrier to many couples?
Yeah, I'm really sorry about that, but we recognise that we should be helping more couples have the actual treatment than the travel and the accommodation costs.
Yes,
with regret, but we just can't. We haven't got a big enough.
It's a massive step forward today. So
thank you.
I would just add off the back of that it, I think, am I right in saying it is still the only healthcare where we send people off island for paid treatment but don't cover their travel though?
Well, I think it's something we're going to have to look at as well
Is that correct?
in the overall.
Does it else cover travel?
No, I think what Deputy Stevenson was saying, that when we send people off island for any other form of healthcare, we currently pay for their travel.
So that's
not that we're the only jurisdiction that does.
It's just- it's-
the only.
Yeah.
Yes.
So I recognise that, but I'd rather that we were helping people have the treatment.
Appreciate that.
Yeah, thank you. Thanks.
Okay. Do you have any further?
No, thank you.
Okay,
Thank you very
well,
much for your answer.
Yeah, thank you for sharing that news with us today, and thank you for your work. Okay, so still on women's health, we would like to ask some questions around maternity and the home birth. We've obviously asked lots of questions on this subject in the past, and there's been some communications from yourselves that we've noted with on your website and in the media, and we understand that there was a course, the Baby Lifeline course, that was being delivered in July. There was a slight delay. It was due to be delivered in April or May, and that was delivered in July. Please could you update us as to the status of the training and the review in this area?
So obviously the training did take place in July, and that was obviously, we couldn't do every single midwife, but that was joint training between ourselves and the ambulance service. And we've got our next training day is in 2 weeks' time. And then we've got a full programme of training throughout 2026. And that's not just with maternity, that's also with the ambulance service as well. As part of our review, we did a whole mapping exercise in relation to where we were with our home birth service, and that was our guidelines, policies, pathways, etc. And the second part of that, then we obviously the ambulance service has come into HCG, so we did some work with them. We did a big mapping exercise with them, and that became evident to us that they have got new staff within their thing, so they had to have the training as well. So we had to make sure that they've got that childbirth emergencies as well. We became aware of the ambulance service data with their response times. So we are working through all of that data in relation to the response times, and also when they've got periods of time where there might not be ambulances available. And we need to make sure that we've looked at pathways, policies and procedures that align with our maternity as well as our ambulance services as well, to make sure that actually we are aware of times and that women are fully informed of the availability of the emergency services if required, because obviously we have got a very strict criteria within our guideline, but we need to now strengthen that with the ambulance service. So that's the piece of work at the moment that we are doing, is working with them to make sure that we've got these policies, procedures and guidelines are all in place, but obviously paramount to all of it is safety. So at the moment we have not got a home birth service, and there's no timeline when that will become active again, but at the moment we are working very closely with the ambulance service.
Okay, thank you. And the training, once
Yes.
you've said some of your staff and some of the ambulance staff have been
Yes.
trained, when will both of those services, everybody be trained? When will
So
that
our
happen?
maternity service, we've got our next training session is in 2 weeks' time, and that's when the maternity service will be almost up to capacity, but it's the ambulance service where we've started on that, and that might not be into 2026 because they have got new individuals come, and they've also got agency within the ambulance service, so we've got to take that all into account.
Okay.
So it had to be something for them to actually answer on behalf of when they believe that all of their ambulance crew will be fully trained.
Okay, Minister, is there anybody here that can answer that? Because obviously the public interest in this is very high, and I think it would be helpful to understand that target date. Or Minister, can you set a target date whereby you would like all of your staff to be
No, I
trained?
can't, and I won't be forced into doing that. This is a public safety issue. I think the team are working as quickly as they can. I think it would be wrong of me to put them under extra pressure to do that. I think we have to put the patient first, and that's exactly what's been done.
Have you communicated though that politically it is a priority, and are there sufficient resources for that training to be carried out at the earliest opportunity?
The resources are there, and I don't think anybody this side of the table needs to be reminded of the public importance of this. I think it was very plain to everybody the last time that we met that it's an issue of great concern to people. But I think it would be wrong to fast track it in such a way as that somebody's life or the child's life might be put at risk.
I think it's prioritising is what I'm asking rather than fast tracking.
No, I'm happy with the level of prioritisation that it has at the moment.
Can I ask a follow-up question regarding you've mentioned the ambulance services as being a significant extra thing.
Yeah.
When did it become apparent that the ambulance services were needing to be trained up as well?
So I think it's always been something that we've done, is they've been but actually looking at it as a whole to get the data about what percentage of training they've got, and obviously they've turnover of staff, making sure that everybody who's new within it have been trained as well. It became part of our clinical effectiveness work alongside the ambulance crew, and as part of that training, so they are very much, it is training together, that the midwives and the paramedic crews are training together. So it's through doing all that review and doing the mapping exercise and the quality improvement that we saw that actually we needed to make sure that they've all got that training as well, and that they've got that childbirth emergencies training. All of them have got it, and not just one or two, that we made sure. So it was all part of that mapping exercise that we did.
So given that you've identified the need,
Yes.
and the work is underway,
Yes.
why is it not possible to say when that training will be complete? Because there's a risk here of an ever-receding horizon.
And I think, you know, you're right, it's about making sure that actually we have worked very closely with the ambulance service, and it would have to be the ambulance service that we could have asked them for, you know, an update on that. You know,
I think, if you don't mind me saying, I think we've got to trust individuals who are clearly competent and doing their best. I'm very, very comfortable with the team that I've got here, and I know that nobody wastes any time. And so I think we've got to stick with the position that we've got here. It'll happen when it happens. It'll happen in a timely fashion, and I don't think there's any chance of drift. That the people we've got this side of the table aren't into that sort of thing.
Sure. I think what we're asking for is drift from where. So I think we'll follow up in writing if you could seek that information for us, so that we could make sure that the public are aware of that, so that people know when to expect that. In terms of the review, then, aside from the training, what other objectives and recommendations are you currently working on?
so our criteria is down, we're making sure that our policy and guidelines, and obviously our policy and guideline for maternity was the one specific, but we now need to work alongside our ambulance crew, and that is, we're absolutely not stepping, we are working with the ambulance crew to make sure that our pathways align with them, and that our response times, etc., are all within it. So that is where we're working at the moment. So our guideline policies in maternity, but we need to make sure that they align with the ambulance service as well within it. Yeah.
Is it so? If paramedics, sorry if I'm not understanding it, have paramedics not been trained in the past in this?
So some have been trained in the past in it, but probably not all of the paramedics. Obviously, you've got new staff that might have come in, and we've very much now taken it that we will be having our paramedics training with our midwives to make sure that they're all getting the same training. Yeah.
And forgive me for pushing the point somewhat, but we're coming up for a year formally without a home birth service. I think other people would say informally it's been months before that. Is that, perhaps a question for the Minister, is that good enough for islanders?
Yeah,
and
it is.
I believe there's some new principles from the Nursing and Midwifery Council about supporting person-centred care for women and babies, and it's very specific that it talks about women's views and choices and preferences being put at the heart of maternity care. It talks particularly about the options for where a woman can give birth, and talks about home birth specifically. I just can't square the circle here that we're a year on from that, and is there a sense of urgency about trying to work towards this in the best interests of everybody?
I've said it before and I've said it again. Yes, there is an urgency. We appreciate it. We appreciated it the last time. But you might find it extraordinary. I don't. The job is being done properly. It's being done comprehensively. That's what needs to be done. It will be done in a timely fashion by good people. And I won't be pressed any further on it. I'm afraid we are where we are. It'll be ready when it's ready, and you've got good people taking care of it. There's nothing more that I can say.
When everybody is trained, is the button ready to be pressed to switch back on the service?
I think from, I do get the principles they've come out, but I think paramount to that, it's all about safety. And I think that's where my role is I've got to make sure it's a safe service and it's a sustainable service. And actually that's for every single woman on Jersey. And I think that's what I could just keep on saying, is that the safety, and we will make sure that we are ready, but it needs to be very much in line with our ambulance service as well as ourselves as well, to make sure that everybody's on the same page and that the criteria is, because one given time, as I've said before, it will never be able to give it 100%, because we have to look at what is the activity within the maternity service and with our ambulance service at any one given time. And we all know that sometimes that can be compromised because of different things that are going on.
And that's
within
always
the
been
island.
the case,
Yes,
hasn't it?
always been the case.
Yeah.
It's not a new thing, but it is about safety, making sure that I can provide that absolute assurance to you all.
Yeah, and just to be clear, when we're asking questions in this area, we are always asking it with the underlying assumption that the service delivered would be a safe one,
Yes.
And we agree with that.
I stand to be
that
corrected, but I
principle.
think we have had problems here before, have we not, in maternity some time ago? There was an incident that...
So, Minister, my next question to you would be, is it your aim to reinstate the home birth service as a funded service?
To the extent that that's possible within the budget, yes.
Okay, thank you.
And as long as it's safe for the mother and the baby, and we have to make sure that we've got enough ambulances to be able to help with do the service.
I mean, this is, I mean, clearly safety is vital, but safety can never be 100%. And So there has to be a point reached at which it's acceptable. I mean, there is a risk that the focus on safety becomes, as I say, a receding horizon where you're never completely sure. Do you have in your own mind a clear point where you will be able to say, yes, I'm comfortable?
I absolutely have got that, and I think then that's when I would be going to the ministers and our chief officer at the hospital as well to give them that assurance.
And you don't see that as 10 years in the future?
No.
What does it look like, that point?
To me, it is about that we've got everybody safely trained, that actually I know when a woman phones up that I'm able to give her that evidence about that, yes, we can provide the midwives within the care for them, and also that we've got our ambulance service is able to provide if they're required to be transferred in for any reason, but that everybody's trained to this highest standard. And that's what I want to make sure.
Thank you. Anyone? No? Want to ask anything on that? No? Okay.
Thank you.
Thank you for your answers there. And the next section that we're going to ask some questions, which is semi-women's health. We appreciate this might be an issue across any gender, but we want to ask around the assessment and treatment of anemia. And I think Constable Shenton is going to open.
So the panel has been made aware that there may be inconsistencies in how anemia is assessed and treated in the island. Does the General Hospital's pathology laboratory follow UK standard haematinic investigation protocols, e.g. ferritin, vitamin B12, folate, reticulocyte counts when anemia is suspected? And are there local protocols or guidelines that outline these investigations?
Simon or Peter? You would be the best person to answer. I certainly can't answer that question, and I'm sure you won't be surprised.
So shall I answer as much as I can?
Yes,
So
please.
obviously in relation to, it's women's health, and I don't know about a specific area, but in relation to pregnancy, we absolutely follow UK guidelines and NICE guidelines, and we do offer the different ones depending on what their level is. We do the normal testing of all women at booking and at 28 weeks, and if they require further testing, they get that done if they are anemic. But we do follow the guidelines on relation to medications as well, and we absolutely do follow them within our guidelines. It's NICE guidelines that we follow, which is exactly what the UK follow as well.
Right. Oh, the question I was asking, it wasn't actually for pregnant women.
No,
It was
okay.
it was for other, especially young women, that it's come to my attention that I think the criteria in Jersey for
The threshold.
the threshold for being diagnosed as anemic is far higher than it is in the UK.
Okay.
That's been brought to our attention. So maybe if nobody can, we could follow these up, couldn't we?
I'm very happy
I'm
to
sure
take
we
that
can find
away.
somebody
Yeah.
to.
Yes.
And I'm very happy to
appropriate
take that
person.
if you put that question in, that we can answer that to go on forward, because it's not something we can answer today.
No, thank you very
Absolutely, we
much.
can.
Thank you.
Yeah.
Sure.
Thank you.
Okay. Do you want to ask any of the other ones on that section, or shall we follow them all?
I think I'll have to follow up because
Yeah.
they all.
Okay.
I think it's it's unfair if you can't really answer them
Not at
today.
Thank you for your efforts anyway.
Thank
we'll
you,
follow
thank
up
you
in
very
writing. Yeah, thank you. Philip, would you like to go on to these ones? So
Eating disorders.
So the next section we're going to move on to is around eating disorder support services provision. So we might have another swap in and out. Would you like to introduce yourself, or did you already?
Did that already.
You've already,
Yeah.
You've already done that. Okay.
Thank you. The first question is whether current referral to treatment waiting times for eating disorder clinic services and JTT services for disordered eating can be stated.
Yes, so for the eating disorder service, the average wait is 21 days from referral to assessment. It's important to describe the eating disorder service. It's a pathway that's got 33 people in it. It's one clinical nurse specialist, part of a psychiatrist and part of a dietitian. That's the specialist service. So lots of people with eating disorders will receive care from that team, but also will receive care from other people, like Jersey Talking Therapies, for example. So if people need psychological support, it's not dedicated within the eating disorder service, it comes from our normal psychological services.
So 21 days from
Referral to
to
assessment.
treatment.
Yep. And there are only 2 patients currently waiting.
I think, did you say it from referral to
To
assessment?
assessment, that's right.
Assessment.
Rather than
Yeah.
treatment?
Yeah.
Right, okay. And there's no waiting time for referral.
it's 21 days. If someone needs to be seen more urgently, so if it's a mental health crisis, for example, they'll be seen routinely by the crisis team first. The way that mental health services works is that referrals come in through a central team. They're triaged by that team. They may see the patient, they may not need to. It may be very clear where the patient needs to go, and then they get referred into the specialist part of the service. But people are seen currently within 21 days for a routine eating disorders referral.
Can I ask, just as a follow-up to your question, the time from the assessment to the treatment?
So it will then just start straight away. So it's not that we just do an assessment and then you wait. That's not true for psychological therapies.
Yeah.
So for psychological therapies, there's a clear differential, and we report differently between referral to assessment and referral to treatment.
Are there any capacity limitations which lead us to need off-island treatment?
So only for inpatient care. So the only time that we would send someone off island for a fair care for eating disorders is if they need care in a specialist inpatient mental health provision. They are highly specialised services. They're regional in the NHS, so lots of towns and cities won't have one. They may be shared between a number of different places, and we would never be able to provide that here. That requires a whole clinical multidisciplinary team of people to look after someone in a hospital setting. There's currently one person off island. Generally, there's one or two.
Can we talk about RFID? Which is something which I learned about today.
Shall I state what it stands for? It's avoidant restrictive food intake disorder. We've been informed.
Is this a major problem in Jersey?
So it is a problem, and certainly my CAMS colleagues tell me that it's a problem that they're thinking about currently. Our criteria for adult eating disorder services would generally not include RFID currently, because of the size of the service, they tend to focus on the people with the most need. But we're currently talking with the Children's Service about an all-age eating disorder pathway, because actually that would make sense in terms of pooling and resources, but it would also potentially allow us to start to think about widening our breadth. So it is an issue. It's an issue that we're thinking about. Certainly, as I say, it's an issue that's talked about more in children's services than adult services. But in the overall thinking about what do eating disorder services look like, we need to consider what we're going to do moving forward around RFID.
I mean, how do you distinguish between a child who simply doesn't like spinach and someone who has a problem?
So it's a clinical assessment. So as with anything else, the diagnosis would be applied following a full clinical assessment. Not just based on the child won't eat spinach, I hope.
Broccoli in my child's case. Can I just ask a quick one on that, Sir Philip? Yeah. So in terms of that pathway being expanded, will there need to be additional budget?
So there will. So one of the things that we've started to do now is think about budget allocation for next year. So as you would expect, we have a variety of potential pressures on budgets. We have a variety of areas where we would like to perhaps to put some more resource in one place, but more resource in one place means less resource in another. So we're starting to think through at the moment about how will we do that for next year.
Okay, and final one, are there any interim measures, as you have told us you've done with other things like the ADHD pathway, is there anything in the interim that you could put in place?
So I think one of the things that we do well and increasingly around eating disorders is working with the third sector. So, we have a good relationship with a number of the charities. The Jersey Eating Disorders Service works well with us around this area. They, for example, have some counselling capacity which we can ask people to think about using if they're waiting for our psychological assessment services. So, I think there's some stuff that we can do, but fundamentally we just need to work out what's the breadth of the service going to be moving forward.
Okay, please would you keep us updated on that service? Yeah. Thank you. We're going to move on now. Is that okay? We're going to move on now to some questions about the rheumatology department.
So I think it was back in May, Minister, you announced that there wasn't going to be a group compensation scheme for rheumatology patients. Can you outline what objective criteria were used to make that decision?
I'm going to hand over, if you will, to Simon.
So it's difficult to give a solid answer on that from my perspective. From the perspective of Health and Care Jersey, we've welcome any applications for compensation from previous patients and or relatives that have been caught up in the rheumatology affair. The decisions with respect to compensation back in when the Minister made his announcements were the decisions at that time, but negotiations are still ongoing with respect to the possibility of a scheme or not. Those negotiations are being carried out by various legal entities and bodies involved, both within the island, but also as representatives of those concerned. So I don't think it's a hard no at the moment, but the Minister, I think, was being honest at the time in terms of where negotiations were at that stage.
So just to clarify, although there was an announcement in May that there wasn't going to be a group compensation scheme, there might be.
I can't say that there would be, and I can't say that there definitely will be, but I can say that certainly discussions with respect to any possibility for that are ongoing.
Sorry, Tom.
No, it's a very complicated area as a layman when you get into the complexities of law, medical law. A lot of uncertainty from my point of view. So I have to really look to the best advice that I can be given.
In terms of at the current situation, if a patient is trying to seek some redress, is their only option to take legal action, or can they engage in a process short of legal action to try and gain compensation?
There is no other process other than engaging in legal action.
So
at this point in time.
Does the department recognise, does the Minister recognise that places an onerous expectation on people who might be suffering quite considerable health implications?
It does, and as I say, it's a very complicated area and it's under discussion all the time. So we haven't reached a particular concrete position as yet.
Can I ask where this is being dealt with? Is it being dealt with in the department? Is it being dealt with by insurers? Is it being dealt with by lawyers?
I think you've covered all three. It is a combination.
Who's in the lead in terms of the scheme which Deputy Renouf is talking about? And what are the criteria for whether there should be a scheme or should not be a scheme?
So with respect to the criteria as to whether there should be a scheme or not a scheme, I think that it's reasonable to say that negotiations are continuing between the legal people on the island and the insurers that represent the individuals and also those people with a specific interest in relation to the possibility of a scheme. I'm not party to those, so I'm speculating, and it would be unfair to the public to speculate in a public forum like this.
I mean, the Minister made an announcement. Was that your decision, Minister?
It's a decision based on advice.
So does the buck stop with you in terms of whether there will be a scheme or not?
Ultimately, I assume that it will. And as I say, I have to be guided in this because it's not an area of specialisation for me at all. It's an immensely complicated business.
Okay. But the decision that was announced has to a certain extent been rowed back on in the sense that it is now.
That was the decision at that point in time. As I say, this is ongoing. So I appreciate that doesn't give complete certainty, and hopefully we can get to a more certain position in the not too distant future.
Can I ask what has changed since that announcement to make you reflect on that?
To be honest, I can't answer that directly, other than the fact that discussions are carrying on with all the departments that were mentioned. As I say, it's an evolving piece of work.
So you mentioned your officer advice. Is it that you've reflected on officer advice?
Yeah. But as I say, I have to be guided in all of this. I don't know as to whether we can put a timetable together as to whether...
I don't think we can put a timetable on that, and it would be unfair to label a point in time where this would be concluded. I think it's reasonable to say that with respect to the possibility, people are still exploring the possibility. I think the Minister was being honest at the time in terms of the advice that he was given, and I think he was not trying to raise expectations of the public as a whole. But that doesn't mean that people aren't continuing to try to what is felt to be the right thing to do for islanders.
Can you update more generally on the mortality learning reviews that have been going on? Where are we with that? We've heard that 5 cases have been referred for the police, I believe. Is the process of assessing past harm complete?
So in terms of Operation Crocus, which was set up to review rheumatology, the process is near conclusion. It concludes at the end of this year. Yes, in terms of those people who had deceased, those have all been reviewed, and the previously reported number of cases that were referred to the Viscount hasn't increased. In terms of the number of cases that the Viscount is looking at, those have been reported in the media over the course of the last few weeks, I believe.
Okay, that's fine.
Just following up, Deputy Reynolds, there are two issues, aren't there? There's the issue of liability, and then there's the issue of compensation if there is liability. And whether or not a scheme is established depends to a large extent, I suppose, on the question of numbers of those people falling within each category. But I think one of the concerns of the panel relates to people who don't have enough money to employ a lawyer and to pursue legal proceedings, unless, of course, they join up with other people to do that. But on the assumption that one's talking about an individual, is there any action which is being taken in the department in order to assist such people to obtain their entitlement?
I think it's very difficult for the department to actually put in place. We are very much open to working with people who feel that they require a degree of compensation, but we aren't equipped in a legal entity to assist those people, and that's why we encourage people to work with members of the law community within Jersey. But I fully appreciate that leaves people at the behest of those people in terms of how they would be able to fund such an entity.
Okay.
What I'm happy to, are you going to
You can
move
add
on?
a brief comment.
I've just been thinking while these questions have been asked. I'm very happy to bring all the threads together and put some focus on this and try and write to you at some point in the future with a fully up-to-date position, if you like, which I think might be helpful. That would be helpful.
Yeah.
Might take a few weeks to bring those threads together because as you can imagine, everyone's got a full agenda, but I think it would be probably quite timely to get all the relevant heads together and come up with something that gives a bit more clarity for everybody that might be out there.
Thank you. I think this is.
I think it would be helpful.
Yeah, I think given the gravity of the issues around this, the public, that would be very helpful. Thank you. Okay, we're going to move on to a different section now, and we're following up to our recent review into ADHD prescription of medication, and Deputy Stevenson is going to lead this one.
So at the end of February this year, I think the waiting list for assessment and diagnosis was at 932 individuals with waiting time approaching 5 years. Can you please provide an update on the current status?
So the current waiting list as at today is 1,026 people. The service receives an average of 25 referrals a month and has capacity to undertake 4 new assessments a week. As we've rehearsed previously here on numerous occasions, some of that is because a vast amount of medical time is taken up with prescribing. There are over 300 people currently on the prescribing list. So the dilemma, they're not all being prescribed for. The dilemma is that the more people we assess and the more people that we seek to treat, the less capacity there is to see new people. So that's simply the dilemma. The prescribing nurse that we recruited started yesterday, so that's good news. So I'm hoping that will have an impact around some of this. Unfortunately, the service has had a significant amount of sickness absence medically, so that's further impacted in the last few weeks on the capacity of the clinic to see people. So we're kind of holding a relatively steady state in terms of assessments. The work is ongoing in relation to prioritisation. The team have met twice, I think, to look at that. They are meeting again on Thursday. So that will then require someone to go through the 1,000 people and prioritise them based upon any criteria that they decide. So they're thinking about, is that a good use of their time, frankly, as opposed to seeing patients. So that's a dilemma that is ongoing for them. This is clearly one of the areas where we need to think about, do we need to put more resource into this service? But if we do, where are we going to take the money from?
So thank you for that update and for the figures as well. I think the one that I missed was waiting times then to get through that. Is it still at 5 years?
So it is, it's approximately the same. Yeah.
Thank you. And I think previously talked about GPs and could there be shared care pathways? I think GPs had rejected that idea in the past. Are those discussions still ongoing?
So they are ongoing. We haven't got any further forward. So certainly since the last time that we were here, it's gone back on one occasion to the committee that makes the decision about whether drugs can or can't be prescribed in the community, and was not supported by primary care. So we remain in the same position that we're in. We've had a helpful conversation with a GP who has a potential alternative model around GPs working into the hospital. We need to explore that further. That may be a potential solution to increasing medical capacity.
Is there anything that GPs are feeding back that would help change that decision for them? What are the barriers for them?
So I think it's interesting. It's one of the things actually that we've started to see now in other jurisdictions. So I think I've said here previously, I came from a place where lots of GPs did shared care prescribing, and that was very much the routine. So the specialist ADHD service did diagnosis and annual review, and that was that really, unless there was a concern. Everything else was done in primary care. That's starting to change in England at the moment. So we're starting to see GPs saying we don't want to do this shared care. We're concerned about the ADHD medication, and starting to withdraw from some of the shared care arrangements. So it doesn't seem that there's an easy answer. The GPs are saying, very consistently, this is about confidence, it's about skill and knowledge, it's a concern about the potential risks around some of these medicines, and it's also about capacity. So we know what the issues are, we know why people are saying they don't want to do it. But fundamentally, we will, if we carry on the current trajectory, we will reach a point where we cannot see anybody new because all of the service is doing is prescribing medication.
Mm-hmm. Thank you. Can you advise on the uptake and attendance at the new Living with ADHD group, and what feedback you've received from attendees, and how the outcomes of this group are being assessed?
Thank you. So I haven't got figures, but I can get those for you easily.
Thank you.
Feedback has been really positive.
Oh,
We've had some really good feedback from people who have said, actually, I now realise this isn't just about waiting for medication. There are some things that we can do. It's not a formal, psychological therapy group. It's very much an information-giving, psychosocial education type group. But generally, the feedback is positive, and we've got more people signing up to the next round. So we're just going to keep on rolling this out. I think it's an initiative that helps people that are on the waiting list, and it's a different lens to the answer to all of the problems that you have with ADHD as medication, because we know that's not the case.
Okay, thank you. That's right. Don't have
Just before we move on to the next section, where is that tipping point? You say about when there'll be no new patients. Have you got a number that you want?
So it's one of the things that we're talking about on Thursday, about we need to model it actually. I think we do need to say at what point can we see no one new because all we're doing is prescribing.
Thank you.
Right, okay, thank you. So the next section, and I'm just noting the time, we are quite short on time, so if we could have the answers as brief as possible.
So Minister, you're bringing a proposition to the Assembly to renew the advisory board and to set up a new partnership board to coordinate and advise you in health matters. There's a slight disparity between what you've said in a previous hearing about the selection of community partners who will sit on the partnership board, focusing on that in terms of them being elected and being representative of their groups or not. Can you clarify, is the intention that the community partners who sit on the partnership board will represent their sector? And if so, how?
Well, they have two roles. As I see it, they are there as representatives. They bring the knowledge from their sector, but the intention isn't that they necessarily come as a lobbyist for the sector. They come with the experience and knowledge of the sector, with a view to contributing to the overall well-being of decision making. Does that make some sense to you?
Do they have a mandate to try and find out what their sector is thinking?
Yes, well, we've done some work. I had a meeting about 10 days ago with a primary care body, and we had discussions around tightening up some of the ways that they operate so that every practice on the island is actually encouraged, not forced, but put under pressure to make sure that they all participate. And similarly, I had a meeting with the chair people of the various health charities, similarly yesterday, about tightening the framework of engagement so that information can flow back down and back up from those entities. Yeah. That's work underway. As I say, we can't put too much in place without knowing whether we're going to have this passed in the Assembly. But as soon as the Assembly, if I'm assuming that the Assembly hopefully will pass this, then we go back and we build on the work that we've done to strengthen those various organisations.
Can I just explore the area of policy that the board will advise you on? So the expectation is that the partnership board will advise you in specific areas of health policy. Is that correct?
It's as much an operational mechanism as an advisory. The advice that I take in the main comes from the Health Advisory Board that sits above the whole enterprise.
So you do not expect the partnership board to advise you on matters of health policy?
Yeah, it will do. Of course it will, because it's actually doing the operational stuff. So there will, as I say, the top guidance will come from an overall policy from the top. The operational guidance will come from the partnership board.
Is that the reason I'm asking this? Is it doesn't appear particularly clear in the proposition as it currently is. There seems to be some dividing line that you're articulating. That some stuff is to do with the advisory board, some stuff is to do with the partnership board. Do you have a clear sense in your mind of where that is?
Yeah, perhaps I don't articulate it properly, but I see the advisory board as people that take a completely external view of the entire enterprise and advise on that and advise on best practice with their experience from having worked elsewhere. And the partnership board advising on more immediate issues because they're an operational board.
Okay. And then final questions around resourcing. I'm just mindful of time. We might have to follow up with some more written questions on this. But in terms of resourcing, it's I think £70,000 has been put aside for it. I think that's right. I stand to be corrected.
Yes.
But that is essentially to pay for the attendance and the people who are on the board. Is it correct to say that there is no secretariat support? So, say research backup, commissioning of research that they might want to do in order to support their work,
Or research officer.
or research officers.
There's no funding for that, is there?
So the £70,000 in the budget, and as you say, that's for attendance and participation, and also for training for community partners to do things, to upskill them, to go out into their sectors and to gather information and views and bring those back. With regard to secretariat functions, research functions, that will be performed within HCJ's existing resources. It will be from a combination of people within my policy team, but also depending on the subject that they're looking at, it will be from within other areas of HCJ. And the secretariat function will be provided by the same secretariat function that supports the existing advisory board.
Is there a risk here, though, of overload in that there are many potentially weighty issues for the partnership board to consider? Where will the sort of authority sit for saying yes or no, you can or can't have that level of support, given existing commitments of staff within HCJ, for example?
Well, as I say, I don't think we can predetermine the complete direction of travel. I think we're going to have to run this for 12 months and see how it goes. It might require some more resourcing, but I don't see that it will require levels that go beyond the resourcing that's available in-house at the moment. The idea is to keep this operational and as lean as we can.
The concern which I have, Minister, about your partnership board, I think, is the extent to which it's going to tie up the time of your senior people, like the medical director and like the director of health policy. You've got an advisory board, you've got a partnership board, you've got provision for committees and subcommittees of the partnership board. When are your people going to have time to do any work?
That's a very good question. I would argue that this will be an advantage rather than a disadvantage. All the only decisions that will be being made by the new partnership board are decisions that are currently being made at the moment. And people spend an awful lot of time making decisions in what I would consider being an operationally slightly discordant way. And I think this is going to bring, over the course of time, when it pans out, it's going to bring a degree of clarity. The right things happening in the right place with the right people. I think there's a degree of confusion because the system has actually evolved in what appears to me as an outsider that's worked in the commercial sector to be quite a hectic sort of approach to things. As I say, it's not ideal. I've asked the question. We did 14 consultations, and I asked at every one of those consultations for all the various sectors, if you were designing a health service from scratch, would you end up with the one that we've got? And on 14 occasions, I was told a very resounding no. So this might not be right, but I feel it is. And when we asked the 14 different sections whether they wanted to proceed with it as it was explained, they all said yes. So I'm hopeful. As I say, health is a big and complicated enterprise, and it needs to be very well structured from a human point of view, so the right people are talking to the right people to make the right decisions, and it needs to be backed up digitally. And as you all know, it's no secret now, our digitisation levels are appalling. So I think we've got to get the human side right, and we've got to get the digitisation right as well. And to map the two things through together.
Just to follow that up, Minister, you mentioned decisions made by those boards, but can you confirm that the ultimate decision-making responsibility will still lie with the Minister?
I think from a public perception point of view, that has to be the case, the way Jersey works, yes.
But it's not just perception, is it, in terms of...
The reality is it's the right professional people's coming up with the right,
And the ultimate responsibility will still lie with whoever is the Minister.
That's correct.
Which means that a minister could reject.
Sorry?
Which means that a minister could reject a recommendation from the partnership board.
Yes, in theory.
Yes, and the terms of reference set out that where the partnership board makes a recommendation to the minister and the minister rejects it, the minister must, in writing, provide their reasons for a rejection of that. So there's full transparency.
Yeah. And I think the safeguard to that is if the Assembly ever thought that there was a minister in place that was taking weird decisions, then it would be the responsibility of the Assembly to remove that minister and replace him with somebody else. So there is a fallback safeguard.
We may follow up with some more detailed questions around that.
Very happy to answer.
Okay, I'm going to try and fit some questions into the last 5 minutes. Thank you for your answers there, Minister. And there was a report published by the CNAG in July around the financial management and internal control of your department. Some of the findings cover budget overruns, weak financial controls, forecasting gaps, many of which you have spoken about yourself to us in previous hearings. Can you identify what specific measures are being taken to prevent the department from exceeding its budget again in 2025?
In specifics, I mean, we haven't got our finance director with us, who would be the best person to give the detail of that.
So,
would you be able to? And
yes, I think there's a series of very regular reviews where we look both as an executive team and within services at budget and forecasting. In fact, we spent the whole of yesterday afternoon doing precisely that in order to understand where we're forecasting the position. In relation to the CNAG review, the response to that is currently being finalised, so it's not yet been lodged with the CNAG. So clearly we can't go into the detail of that here yet. But
when
that
is
will
that
be
due?
published. I don't know the date. We can check that for you.
Okay, thank you. Does anyone want to?
I guess the central point you're making really has been all along that the reason you go over budget is because you're underinvested. I guess the question is, what will you do after the budget is published? You've got extra money. What assurance have we got that you won't again overspend? what's being put in place to
Well, as I say, I don't deal with the day-to-day budgeting, but I certainly will, if we can achieve the extra money that we're asking for. I'll be putting a great deal of pressure on everybody to make sure that this time next year we come in within budget.
Okay.
That's as much as I can actually do from a layman's perspective. But I think everybody this side of the table understands the gravity of the situation. I think they'll be very grateful if the narrative can change and that they've got a chance, they've got enough money to have a chance of coming in within budget. Because I think that people here have felt sort of vilified to try and deliver a service when always they've been short of money, and that's a difficult place to be, and I think we've possibly lost good people as a result of the pressure that imposes upon people. So,
I'm sorry to hear that. I think we will have to follow that up with
Yeah.
some questions in writing, as we do have several more. We've got a couple of sections which we're not going to cover, but we might be able to squeeze in, if Constable Shunter wants to squeeze in a question on mental health services. Do you want to ask maybe the first question
I've
on that?
lost it, sorry. Oh, sorry.
It's okay.
Yeah, sorry, yeah, thanks. So the Jersey Recovery College, which provided recovery education and community mental health courses, closed in August 2024 because of unsustainable finances, removing a valuable layer of support. So how does HCJ plan to reduce the backlog in psychological therapy given the current average wait of 184 days?
So there's no relationship at all between the Jersey Recovery College and the backlog for psychological therapies. They're two very, very different things. And we have replaced the Jersey Recovery College with a recovery hub, which is now up and running with a whole series of different groups. And we can provide more information in relation to that if that's helpful. But that does not relate to the waiting list for psychological therapies at all. Psychological therapies are delivered at tier. So we have the first tier is around counselling and support. We've recommissioned that through the listening lounge, and we've changed the contract in relation to that to provide more capacity. The second tier is Jersey Talking Therapies, which is essentially manualised treatment. That's a place where we have had quite a difficulty around waiting for treatment, and not waiting for assessment, but waiting for treatment. We have increased the staffing number within the service, and there's a review being led currently by the service manager thinking about is there something else that we can do to manage that. It's dropped, so we've seen some recovery in the last couple of months. Unfortunately, it's gone up slightly in the last month, but you know it will fluctuate.
Okay.
The biggest challenge is around specialised psychological therapies, so psychologists, clinical psychologists, who do particular trauma type work, for example. That's where the real weight is. We are increasing the number of posts that we have in the psychology service. And we are about to advertise 3 consultant psychology posts and a number of other middle grade psychology posts. We are reviewing how we then structure psychology, because psychology is structured in a number of different ways, and I don't think it always gets people to the place that they need to be as quickly as possible.
Okay.
So,
Thank you for your answers. We're just going to ask a brief one.
I want
About
to ask one question about PFAS, Minister. Obviously, the expert panel's produced its third report, and the government has responded to that third report, and it involves some treatments and pathways being offered for members of the public who have been affected, giving Professor Bradley a chance to get into position.
to coming back to the table.
for the last
Phew.
slightly
Although it's
over.
partly a ministerial question, I think, because
Yeah.
the question is that's going to, obviously, that's a service that will be provided to the public. I think £700,000 has been mentioned in relation to that. Is that money covered within the budget? And if it goes beyond that, what is the expectation in terms of funding for that service?
In terms of the treatment, Peter, is that included in the sum of money that we're looking
Yes,
for, or
yes,
is it
it is.
within the sum of money that we have?
Yeah, so the sum that's quoted is over several years, and all the costs are included in that sum. Yeah.
So at the moment, we have a treatment pathway, set of pathways, and all of the money that will be needed to cover that is within a budget. Okay.
Okay, I think we're going to have
I
to
think,
stop
sorry to get you there,
with,
but I think I just wanted to
yeah.
get clarity for that.
Yeah, thank you. We do have a few other questions on that topic area, and as always, we'll send our follow-up letter. But thank you very much for your time today. Minister, did you want to add anything final before we close the hearing?
No, I can't think of anything offhand.
Okay.
More money.
Well, I can make a plea that politically, if you can vote for all the money that we're looking for, I think we can do great things with it. So, yeah, if I
They
can
have
finish-
separate debates about that.
finish on that note. That's
Thank
fine.
you for your time today,
Thank you very
everybody
much.
who's attended, and I'll close the hearing.